So hey guys, welcome to my brand new channel which I called Study Medicine with me. And in this channel I study medicine related books, especially PDF. And I think this is very good initiative for me as well as for others who want to study medicine through YouTube. I really think that this thing can motivate others to study. Just seeing one of my thumbnail in their home screen might motivate them to study. So this is what I want, and today in this video I'm going to study the coronary artery disease and the other topics related to cardiovascular system. So I'm going to study for about 3 hours straight. So let's begin. So coronary artery disease. Coronary artery disease is the most common form of heart disease and the single most important cause of premature death in Europe, the Baltic states, Russia, North and South America, Australia, New Zealand. Okay. So by 2020, it is estimated that it will be the major cause of death in all regions of the world. Okay. So in UK, 1 in 3 men and 1 in 4 women die from coronary artery disease. Okay. And estimated 230,000 people have myocardial infarct each year. Okay. And approximately 1.3 million people have angina. The death rates from coronary artery disease in the UK are among the highest in Western Europe. Okay, it is the highest in case of UK. More than 140,000 people. Okay, about 140,000 people of the UK are suffering from coronary artery disease. So it is one of the most important disease that you can expect in medicine practice. Okay, but are failing particularly in the younger. Okay, this is good news. I think particularly these are failing particularly in younger age groups. In the last 10 years, CAD mortality has fallen from 42% among the UK men and women aged 16. However, okay, it has been fallen. However, Eastern Europe and most of the Asia. Okay, though in Western Europe there was cases previously, and still it is there cases. However, the younger people are not suffering that much. But in case of Eastern Europe and Asia, the rates are actually increasing. Disease of the coronary arteries is almost always due to the atheroma and its complication. This is very important line to understand. So it is always due to the atheroma and complication of atheroma. So what might be the complication of atheroma? It might be particularly thrombosis. So there might be formation of a thrombus in a coronary arteries that might lead to coronary artery disease. Okay, and occasionally the coronary arteries are involved in other disorders. Arteries are involved, so there might be other disorders such as aortitis, polyarteritis, and other connective tissue disorders. So aortitis is inflammation of aorta, I guess, and polyarteritis is inflammation of various small-sized arteries, I guess. Yes. And in that case the coronary artery could be affected as well. That might lead to this coronary artery disease and other connective tissue disorders. So stable angina. Let's select a color. So let me select the pencil tool. How can I do it? So let me think how to do it. I need to go to this view, comment section, annotations. Okay, so here I get pencil tool. Okay, turn it off. Okay, so coronary artery disease clinical. So here are the clinical manifestation of coronary artery disease: stable angina, unstable angina, myocardial infarction, heart failure. Okay, arrhythmia, sudden death. Okay, so and this one is the pathology of the of the coronary artery diseases. So it can be manifested, coronary artery disease can be manifested as stable angina. So what happens in stable, so how it is, how the condition is approached is that, okay, there is the in pathology of the stable angina is ischemia due to fixed atheromatous stenosis of one or more coronary arteries. Okay, so there is already atheroma in the people suffering from coronary artery disease. So when this atheroma, so actually these atheromas are from the beginning, when the child is, before the child is birth actually. So whenever this atheroma get hard, so this condition is so hard, and that might lead to ischemia, which means decreased supply of blood in heart. That might lead to this condition called stable angina. So in unstable angina, ischemia is caused by dynamic obstruction of coronary artery due to plaque rupture, or erosion with superimposed thrombosis. So in unstable angina also there is ischemia, but there can be, the ischemia is much more severe as it is produced by a rupturing of a plaque that can block the coronary artery very much more than case of stable angina, or there might be erosion with superimposed thrombosis. Okay, this erosion with superimposed thrombosis, I could not get it. Superimposed thrombosis, let's leave it. So myocardial infarction, in case of myocardial infarction, there is myocardial necrosis that is caused by acute occlusion of coronary artery due to plaque rupture or erosion with superimposed thrombosis in this case as well. So there is basically necrosis of heart muscles. In case of heart muscle, there is myocardial dysfunction due to infarction or ischemia. So it is basically myocardial infarction, but much more severe, so severe that the heart could not perform well. And arrhythmia is altered conduction due to the ischemia or infarction. So okay, whenever there is loss of blood supply to the heart, the heart obviously could not perform well. So there might be altered contraction, relaxation of heart, which causes arrhythmia ultimately. So and the last one is sudden death. So coronary artery could be manifest as sudden death. Ventricular arrhythmia, okay, ventricular arrhythmia, or systole, or massive myocardial infarctions. Massive myocardial infarctions can cause sudden death. So these are the things that might lead to the sudden death in case of coronary artery disease. That's all. So we're talking about stable angina now. So angina pectoris, the symptom complex. It is symptom complex caused by transient myocardial ischemia, okay, and constitute a clinical syndrome rather than a disease. So this one is a clinical syndrome rather than a disease, and it may occur whenever there is an imbalance between myocardial oxygen supply and demand. Okay, so whenever there is disruption between myocardial oxygen supply and the angina occurs. So coronary atheroma is by far the most common cause of angina. So okay, although the symptoms may manifest, maybe a manifestation of other forms of heart disease, particularly aortic valve disease and hypertrophic cardiomyopathy. Okay, clinical features. The history of the most important factor in making the diagnosis. Okay, it is. The history is the most important factor in making the diagnosis. Okay, stable angina is characterized by central. Okay, in stable angina there is central chest pain, discomfort. This is very important. There is central chest pain that might radiate to the left arm and to the neck region, and obviously there would be a breathlessness and discomfort any breathlessness or discomfort that is precipitated by exhaustion or other forms of stress. Box 18.51. So these are the factors that precipitates the angina. So what are these? What are those? Those are physical exertion. Obviously, the exercise and heavy meals might do the work, and cold exposure as well, and intense emotions. Okay, intense emotions. Yeah, and these are the commons. And what are the uncommon things that exacerbate the angina? So lying flat on the ground and vivid dreams. Okay, this might do the work. Okay, and is promptly relieved by the rest. So it is relieved by the rest. The stable angina is relieved by the rest. When it is precipitated, it could be relieved by the rest. Okay, what are these few? 18.17, 18.17, 18.17. Okay, I need to go very. Okay, what are these? Ischemic non-cardiac chest pain and ischemic cardiac chest pain. What are the difference? So first one is location. This is central and diffuse. Non-cardiac chest pain is peripheral and localized. Okay, radiation. I've already talked about it. The jaw, neck, shoulder, arms are occasionally jaw, neck, shoulder, arms are occasionally back. Others are no radiations are there. This tight squeezing, choking character. Tight squeezing and choking. Sharp stabbing and catching. Catching. Tight. It is tight squeezing and choking. So precipitated by what factors? Obviously, it is precipitated by exertion and emotions. And the non-cardiac chest pains are actually spontaneous, not related to exhaustion. Okay, it has nothing to do with the exhaustion and various factors that I have talked, various common and non factor that we have talked just before, and it is provoked by posture, respiration, or palpitations. So the posture might exacerbate the pain in case of non-cardiac chest pain. So rest, quick response to nitrate might improve these conditions. These are relatively limiting factors, but I think it is only in case of stable anginas, not in case of unstable anginas. So not relieved by the rest flow or non-response to nitrates. So what are the associated features? Those are breathlessness and respiratory, gastrointestinal, locomotory, or psychological. Identifying ischemic cardiac pain. Okay, balance of evidence. So where were we? Okay, not here. Okay, this thing is very irritating in case of PDF. It takes a time to find where I was before. So what I do is I just go to view the comment section, and here I just click out this, and I would be back where I was before. So this was it. So this is it. So where were we? We were here. Some patients find the discomfort comes when they start walking, and that later it does not return despite greater effort. Discomfort comes when they start walking, and that later it does not return despite greater effort. Warm-up angina. So what is warm-up angina? So some patient might find the discomfort comes when they are okay. When they start walking, they might find the discomfort, and later it does not return to return despite great effort. Okay, so some people might experience angina when they initially start to walk. However, it doesn't come when they are walking after a few minutes. So that is called warm-up angina. So physical examination is frequently unremarkable, but should not include a careful research for evidence of valve disease. but should include a careful research for evidence of valve disease. Okay, particularly aortic valve. Important risk factors, example hypertension, diabetes mellitus, left ventricular dysfunction. Okay, important risk factor might be hypertension, diabetes mellitus. These are the one of the most important causes that might lead to the coronary artery disease. In diabetes mellitus, there might be basically they help in formation of atheroma, I guess. And yes, hypertension actually helps in rupturing of atheroma that might lead to the conditions such as unstable anginas, stable anginas might be. So left ventricular dysfunction in case of cardiomegaly and gallop rhythm, cardiomegaly. Other manifests left ventricular dysfunction, cardiomegaly, other manifest of arterial disease, peripheral vascular disease, and unrelated conditions that may exacerbate the angina. So investigations, this thing is very important. So what are the investigations that we send during the coronary arterial disease? So it might include something. So it's a resting ECG, electrocardiogram, if you don't know. So the electrocardiogram may show evidence of previous myocardial infarction. But is often normal even in the patient with severe coronary artery disease. Okay, so when you do the resting ECG, it might give you the hint that previously there has been condition of MI, but even the patient is just suffering from the severe coronary artery disease, it doesn't show it. Okay, occasionally there is T-wave flattening or inversion of some leads. Okay, T-wave flattening or inversion of some leads. So this is so no. So list, okay, here's the figure. So there might be T-wave flattening. So the here, right here is P, Q, this one is Q, this is R, S, and T. So there might be a flattening of a T-wave as T-wave and inversion of some leads. So there are different leads in case of electrocardiogram. There might be inversion of some leads. Inversion of some leads, providing non-specific evidence of myocardial ischemia or damage. So this T-wave flattening is not that specific. It just give a hint. The most convincing electrocardiogram evidence of myocardial ischemia is the demonstration of reversible ST segment depression. So demonstration of reversible ST segment depression or the elevation, okay, or without the T-wave inversion or without the T-wave at the time in the patient experiences symptoms. At the time when the patient is, okay, at the time when the patient is experiencing the angina, there might be a reversible ST segment depression, or there might be elevation as well. That would ultimately indicate to the electrocardio. That would indicate the coronary disease. Okay, so this was resting ECG. So exercise ECG. So I think yeah, this is very common, I guess. In exercising ECG, the patient is said to run on treadmill or bicycle ergometer, where he or she is done. They do so until they experience the angina, and they would be recording electrocardiogram by the side, I think. Yeah, so let's try an exercise tolerance test, ETT. Exercise tolerance test, it also calls exercise tolerance test, is usually performed using a standard treadmill or bicycle ergometer protocol while page number 34. While monitoring the patient ECG, blood pressure and general condition. Planar or downsloping ST segment depression of 1 millimeter or more is indicative of ischemia. Upsloping of ST segment depression is less specific and often occurs in normal individuals. Upsloping of ST depression is less specific and occurs okay. So there might be a planar or down slope. This might be very well explained, this figure right here. Yeah, this is the figure. This is the figure of no top. Okay, not there. Forms of exercise induced ST depression. Exercise, okay. So ETT, exercise tolerance test, also known as exercise induced ST. Okay, exercise ECG. Those are the same thing, I think. ECG, exercise ECG. Those are the same thing. What happened that those cases are that there might be a planar ST depression, usually indicative of myocardial ischemia. So this one is planar ST depression. They are called planar because this is plane, I guess, and this depression of this depression, because the normally it will go like this. So there is depression of ST segment. This one is S, and this one right here is ST segment. So there is depression, and there is planar depression. So in this case there is depression, but it is not plane like this. Like this. It is a sloping, so it is called down sloping depression. Okay, also usually indicative of myocardial ischemia. So this one is actual indicative of myocardial ischemia. So as I've already talked, myocardial ischemia might be caused due to various pathological factor that I was already discussed, that we have already discussed. So these are the factors that causes myocardial ischemia. Planar ST depression is usually indicative of myocardial ischemia. This one is indicative of myocardial ischemia. Upsloping depression may be normal finding. Upsloping depression may be normal finding. So this one is actually a normal finding. This is not pathological. This is upsloping. Okay. So positive exercise test. Just this only. Positive exercise test. What does that mean? Positive exercise test. Does that mean that the patient is suffering from ECG, or does that mean that the patient is suffering from CAD? The resting 12 lead ECG shows more minor T-wave changes in the inferolateral leads, but is otherwise normal. Inferolateral, okay, I need to understand what is inferolateral leads. So for that we need to study electrocardiogram, and we are not there. Okay, otherwise it is normal. So the resting, okay, in case of resting, we have already, there would be inversion of a T wave, I guess. Study like this T wave flattening or inversion of some leads. Inversion in some, okay, there might be inversion of T wave in some leads. So resting 12 ECG shows some minor T-wave changes in the inferolateral leads, but is otherwise normal. After 3 minutes exercise on a treadmill, there is marked planar ST depression. Planar ST depression. So after the resting ECG, the person is said to do the exercise tolerant, says to give the exercise tolerant test or the exercise ECG after 3 minutes, and in that there might be a planar ST depression as in lead V4 and V5 right offset. Subsequent coronary angiography revealed critical 3 vessel coronary artery disease. This is okay. So this, I will explain this figure. So in case of resting ECG, there is T-wave changes in inferolateral leads. However, just after the resting ECG, the patient is said to do the tolerance, the exercise induced exercise electrocardiogram, exercise ECG, and at that condition, in ECG we can see the planar ST depression. In which lead? In V4 and V5. This might come in the MCQs. So subsequent coronary angiography revealed critical 3-vessel coronary artery disease. Subsequent coronary angiography revealed critical 3-vessel coronary artery disease. Risk stratification in stable angina. Okay, layering stratification just means layering. Stratification means layering. So layering of risk. So from high risk to low risk in a stable angina. Post-infarct angina. So what are the high risk anginas and low risk anginas? It just explains what are the so patient with angina might be at high risk or low risk. So we need to differentiate between the high risk patient and low risk patient because the condition of medication depends upon it. So the patient when comes with a post-infarct angina after infarctions of the artery, if the patient comes with the angina, then those are high risk angina. And the patient who in exercise tolerance test have poor effort tolerance, good effort tolerance. Effort tolerance. So we need to know this effort tolerance. I'm just taking a note. Effort tolerance. What is effort tolerance? Effort tolerance. So there is at high risk, if there is poor effort tolerance, then it is called the patient is said to be at high risk. However, if there is low risk, at low risk there is good effort tolerance. For tolerance. So ischemia at low workload. So there might be ischemia at low workload. Okay, during the exercise tolerance test, if initially within the starting of the test, if the person experience stable angina, then the person is at low workload. High workload. Okay, left main or 3 vessels disease. Left main or 3 vessel disease. Single vessel or 2 vessel disease. Poor LV functions and good LV left ventricular functions. Okay, there is the high risk patient has poor left ventricular function. However, for the if there is good left ventricular function, then the patient is said to be at low risk of stable angina. So this was all about it. So exercise testing is also a useful means of assessing the severity of coronary disease. Exercise testing is also a useful means of assessing the severity of coronary disease and identifying the high risk individual. Exercise. Okay. So what does it says? It says that this exercise testing is very useful means for assessing the high risk or low risk of the angina. For example, the amount of exercise that can be tolerated can determine if the person is at high risk or low risk. And the extent and degree of ST segment change. The ST segment is So it's the extent and degree of ST segment change. I think it should be less than 1 meter to 1 meter, something like that. 1 millimeter. Yeah, here is it. 1 millimeter. Sorry. 1 millimeter. So its extent. So ST segment's depression and its extent might give a hint that if the patient is at high risk of stable angina or low risk of stable angina. Exercise testing is not infallible and may produce false positive results in presence of digoxin therapy. Okay. Exercise testing. I think I just missed something. No. Exercise testing is not infallible and may produce false positive result in the presence of digoxin therapy. So I just need to know this term, infallible. So just wait a minute. I'm searching it. Infallible. incapable of making mistakes or doing wrong. Okay. Exercise testing is not so it is not always right. Thus, it does just mean that and may produce false positive results in the presence of detoxing therapy. Detoxing therapy. So okay, so if the patient is already having a detoxing, the patient. So I need to sort about detoxing as well. I forgot where it is used. I guess it is used. Okay, detoxing is derived from leaves of diesel. I don't need this. Detoxing has been heartbeat stronger. Okay. Detoxing is given. I think it is given the myocardial infarction, heart failure. It is given to treat the heart failure. It's also used to treat the arterial fibrillation. So when the patient does the exercise tolerance test in case of detoxing therapy, the patient is not that patient. So when the patient is given detoxing, so when the patient is already on detoxing therapy and he performs the exercise tolerance test, then the patient is not. So the test is false. Just might give the false positive result. False positive result. Okay. So left ventricular hypertrophy, bundle branch block, left ventricular hypertrophy, which just means there is not just a detoxing therapy, but there are other factors as well that might give you the false positive test or for exercise. So these are the things that we need to take a point of what I'm just reading here. So this is number one, detoxing therapy. Number two, left ventricular hypertrophy, increased left ventricle. Okay, bundle branch block or WPW syndrome. I have no idea what does this mean, WPW syndrome. And bundle branch block, this bundle of his in heart, which sends the information to the heart. I don't know what does that mean. It has to do with something with the bundle of his bundle branch block. PUNDL bundle, PRA, ancient branch block. Okay, what is this? Bundle branch block is either a complete or partial interruption of electrical pathway. Okay, I was kind of right, This, so in case of complete or incomplete interruption of electrical pathway inside the heart, there might be a false positive test in case of exercise induced ECG. Detoxing therapy, left ventricular hypertrophy, bundle branch block, and WPW syndrome. I need to know what is WPW syndrome. WPW syndrome. Okay, this mistake, but no problem. How is WPW syndrome treated? So what is WPW syndrome? Damn it. Okay, here we have it. Here we have causes, symptoms. What are the symptoms of WPW? Common. It is congenitally abnormality. Okay. Symptoms include chest pain, palpitation, pallor, very fast heartbeat. Most often it appears only in teens. Radiofrequency ablation and medication can cure this condition. Cause. So it is basically a congenital anomaly of the heart. There's no full form. I need the full form of WPW. Complications. Oh, I need to change my laptop, damn it. What is happening? Okay, what is happening, damn it? So these are the ECGs. What is the defect out here? I just need to know how to read this ECG. I just need to know this. Okay, tomorrow I will be studying ECG. That I need to know. Okay, so WPW is just a congenital syndrome of heart. Bundle branch block is defect in electrical signals within the heart. That might be either partial or complete block of informations. the predictive accuracy of exercising test is okay. The predictive accuracy of the exercise test is lower in women, okay, than in men. So accuracy is more in case of men than in women. And this test should be classed as inconclusive rather than negative. So if the so this is very important. The test should be classified as inconclusive rather than negative. The patient cannot achieve an adequate level of exercise because of the locomotor or non-cardiac problems. So patient might often the test might often give no result. So that doesn't mean that the test is negative. That just means that it is inconclusive, because it is not that specific test. I would say specific is the word. And other form of stress testing, myocardial perfusion scanning. Other forms of stress testing also can be different. So myocardial perfusion scanning. Myocardial means heart perfusion scanning perfusion. So this might be helpful in the evaluation of patient with an equivocal or uninterpretable exercise test and those who are unable to exercise. This may be helpful in the evaluation of patient with an unequivocal or uninterpretable exercise test. I need to shit. Unequivocal or interpretable exercise test. Okay. It entails obtaining those who are unable to exercise. It entails obtaining synthesians. This may be helpful. Okay, I'm going to study this myocardial perfusion scanning right again. Myocardial perfusion scanning. This may be helpful in the evaluation of patient with an equivocal or uninterpretable exercise test and those who are unable to exercise. Okay. So in case of exercise ECG, if there is no particular, so there's no specific finding, and so the person is advised to do the myocardial perfusion scanning. Similarly, it is advised to the person who cannot exercise as well. So it entails obtaining CT scans of myocardium at rest. It entails obtaining CT scans of the myocardium at rest and during stress. Either exercise testing or pharmacological tests such as controlled infusion of Davidson. After the administration of intravenous radioisotope such as technetium tetrophosphine. Very important. Sorry. It entails obtaining CT scans of myocardium at rest and during stress. Either exercise testing or pharmacological tests such as a controlled infusion of Davidson after administration of intravenous radioactive isotope such as technetium. Either exercise testing or pharmacological tests such as a controlled infusion of Davidson after administration of intravenous radioactive isotope. Thallium and tetrophosphine are taken up by viable perfumed myocardium. A perfusion defect present during stress but not at rest provides evidence of reversible myocardial ischemia, whereas a persistent perfusion defect seen during both phases of study is usually indicative of previous myocardial infarction. No. I think my brain is hanging. I need to take a rest. I'll be taking rest for 5 minutes, then I'll be back. So I'm back with almost 10 minutes break. I was supposed to take 5-minute break, but I couldn't help that. So we're at myocardial perfusion scanning. So now let's talk about stress echocardiography. Let's go through the stress echocardiography. This is an alternative to the myocardial perfusion scanning and can achieve similar predictive accuracy. It uses transthoracic echocardiography to identify ischemic segment of the myocardium and areas of infarctions. The former, there's a difference right here. So former, which means myocardial perfusion scanning, characteristically exhibit reversible defect in contractility during exercise or pharmacological stress, and later do not contract at rest or during stress. I didn't understand. I didn't get it. I didn't get it. I will talking about this figure right later on. So, stress cardiography. This is an alternative to the myocardial perfusion. Okay, scanning, and can achieve similar predictive accuracy. So both are not that different. Both are similar. It uses transthoracic echocardiography. So this it uses echocardiography. This is new technology. That is transthoracic echocardiography to identify ischemic segment of the myocardium. To identify the ischemic segment of the myocardium and areas of infarction. The former characteristically exhibit reversible defect in the former, which means the myocardial perfusion scanning characteristically exhibit reversible defect in contractility during exercise or pharmacological stress, and the latter do not contract at rest or during stress. Do not contract at rest or during stress. Okay, this was it. So coronary arteriography. What do you mean coronary arteriography? So just going on stress echocardiography, it is similar to the myocardial perfusion scanning, and it uses actually transthoracic echocardiography technology to identify ischemic segment of a myocardium. So if there is any ischemic segment in the myocardium, it will identify it, and it will identify it used by using the transthoracic echocardiography. So the myocardial perfusion scanning exhibits reversible defect in contractility during exercise. Reversible defect. If there's any reversible defect in contractility, it is identified by the myocardial perfusion scanning. Reversible defect. If there's any reversible defect, it is identified by the myocardial perfusion scanning during exercise or pharmacological stress or latter, and the latter do not contract at rest or during stress. And the latter do not contract at rest or during stress. So, stress echocardiography. So there is just no stressing present in this case. The name is given stress echocardiography, but there is no stress, external stress. This might be expensive than this because there's something echocardiography thing going on right here. So in myocardial perfusion scanning, the drug Davidson is given with a intravenous radioactive isotope such as technetium tetrophosphine. The thallium and the tetrophosphine are taken up by viable perfused myocardium. So it is taken by the myocardium. A perfusion defect present during stress but not rest provides evidence of reversible. A perfusion defect present during stress but not at rest provides evidence of reversible myocardium ischemia. A perfusion defect present during stress but not at rest provides evidence of a reversible myocardium ischemia. Persistent perfusion defect seen during the both phases of the study is usually indicative of. Okay, so let's go to the coronary arteriography. Coronary simply means the artery denotes the artery, and arteriography means, what does that mean? Arteriography. This just leave it. This provides a detailed anatomical information. Graphy means it gives the idea of how the artery is. This provides detailed anatomical information about the extent and nature of coronary artery disease. This provides detailed anatomical information about the extent and nature. This provides information about extent and nature of coronary artery disease. Okay. It is 18.51. I won't go there. And usually performed with a view to coronary artery bypass graft. Okay, so if you are expecting coronary artery bypass graft, so I think I know about this coronary artery bypass graft. It is generally given. So in it, the graft is taken from the saphenous vein, I guess. I need to see the CA, which is coronary artery bypass graft. Saphenous vein is used in this case. Okay, medical term. What is coronary artery bypass? These are type of surgery that improves the blood flow to the heart. Coronary heart disease. Coronary heart disease is a disease in which vacuous substance called plaque. Okay, I didn't need to know that from here since I've been studying it. Coronary artery bypass graft. Is surgical. I need to get this in detail. Okay, where could I get it? Let's see this extension. No. Coronary artery bypass graft is a surgical procedure used to treat coronary heart disease. It diverts the blood around narrowed on. So I just think that. No, I'm not sure. Shit. Just a minute. So management general measures. How to manage this condition? No, we were at coronary arteriography. Okay, it is done with the intention of to do the CABG. The full form of CABG is coronary artery bypass graft surgery or PCI, percutaneous coronary intervention. These are the important things. Percutaneous coronary interventions. And in some patient, diagnostic coronary angiography may be indicated. In some patient, diagnostic and coronary angiography may be indicated when non-invasive tests have failed to establish. Diagnostic coronary angiography may be indicated when non-invasive tests have failed. When non-invasive tests have failed to establish the cause of atypical chest pain. Okay. So when non-invasive tests have failed to establish the cause of atypical chest pain, this is coronary angiography is done. The procedure is performed under local anesthesia. Okay, it should be done under the local anesthesia. That means it is painful and requires a specialized radiological equipment, cardiac monitoring, and experienced operating team. So this is performed with the experienced team and experienced team and fancy machines. So management and general measures. The management of angina pectoris involves a careful assessment of likely. Okay. So management of angina pectoris involves careful assessment of likely extent and severity of the arterial disease. So there should be assessment of the disease and identify the risk factor, identification and control of the risk factors such as smoking, hypertension, and hyperlipidemia. So then we need to identify the risk factor and try to control it for the management. And the use of measures to control symptoms. The use of measures to control the symptoms. The identification. Okay. The use of measures to control symptoms. The identification of high risk patient for treatment to improve life expectancy. The identification of high risk patient to improve life. The identification of high risk patient to treatment. Okay. So management, identification of high risk. So high risk patients will be identified for the treatment to improve their life expectancy. Symptoms alone are a poor guide to the extent of coronary artery disease. Okay, the symptoms alone are poor guide to the extent of coronary artery disease. Stress testing is therefore advised in all patients who are potential candidate for revascularization. Symptoms alone are poor guide to the extent of the coronary artery disease. Stress testing is therefore advised in all patients who are potential candidates for revascularization. An algorithm for investigation and treatment of patients with stable angina is shown in figure. Okay. Symptoms alone are a poor guide to the extent of coronary artery disease. Stress testing is therefore advisable in all patients who are potential candidates for revascularization. I'm just stuck in this terms. Symptoms are poor guide to the extent of coronary artery disease. Okay, this is the poor guide. Symptoms, only symptoms is not good to identify the disease as coronary artery disease. So there is stress testing is therefore advised. So stress testing is should be advised in that case. An algorithm for investigation and treatment of patient with stable angina is shown in 18.66. So algorithm is shown. Should we go to there? Yes, I think we should go to the algorithm. Okay, where the algorithm? Okay, this one is the algorithm for treatment of a patient with angina, I guess. Stable angina. So when stable angina comes, what we need to do? So when the patient comes with the stable angina, these figures are very good. I like this kind of figures. Stable angina. Okay, when the patient comes with stable angina on effort, there should be at first there should be stress test, and if the stress test is positive, if the stress test is positive, lifestyle advice, secondary prevention, and anti-anginal therapy should be done. Okay. So in lifestyle advice, the patient should be told to have less of a fatty foods that and the food that causes hypertensions, oily foods. Those are simple things. Okay. And secondary prevention and anti-anginal therapy might be the drugs such as glycerol nitrate, like that, or aspirins. No, aspirin is not an anti-anginal drug. Aspirin. I'll be talking about this later. I think there's something about aspirin later. And anti-anginal therapy. Okay, so if it is positive, these are given, and if it is negative, then consider CT coronary angiogram and review diagnosis. Consider CT coronary angiogram. Okay, coronary angiogram is, if it is negative, then test is negative, then we must do something. So these things are done and review the diagnosis. Okay, and the diagnosis is reviewed. So from these two things are done at the same time, I guess. So the lifestyle is given as well, and there might be persistent symptoms. If the symptom persists, okay, so lifestyle, if the patient is, so after this advice, the patient might be at high risk or not. If they are at high risk, there is invasive coronary angiography. Same angiography we talked here. Yeah, I think so. Coronary arteriography, angiography. This difference between arteriography and angiography. Is there a difference? I think those are the same terms, coronary arteriography and angiography. Angio means blood vessels, artery means angio. Angio means veins and artery as well, both. So angiography, okay, and is suitable for revascularizations. Yes, then PCI or CAB. Okay. These are so angiography and arteriography is both the same thing. If the patient is at high risk, then he should be so if the patient is still at high risk after the lifestyle advice, secondary prevention, and anti-anginal therapy, then he should be advised to have invasive coronary angiography. From invasive coronary angiography, we might reach to two conclusions: if he or she is suitable for revascularization or not. If yes, then he or she should go for PCI or CABG. What are the full form of CABG? The full form of CABG was coronary artery bypass graft. PCI was percutaneous what? PCI percutaneous intervention. No. Percutaneous Yeah. Percutaneous coronary intervention. I just forgot the coronary. It was in my mind, but okay, percutaneous coronary I need to know about percutaneous coronary intervention. I didn't know. I don't know about it. I just have heard the term CAB previously when I was studying anatomy, I guess. PCI. PCI. Percutaneous. Yeah. Intervention in UK. Intervention recovery. Okay. Continuous audit that calls information about the percutaneous coronary. No, what the hell? Yeah, here we go. Percutaneous coronary intervention is a non-surgical procedure. It is non-surgical procedure to treat the narrowing of the coronary arteries of the so I think this one is very good than CABG. CABG is more invasive than percutaneous coronary intervention. Percutaneous, I think it is onto the skin. The process involves combining coronary angioplasty with sterning, which is the sorry. So I just knew about it a little bit. I don't need to go detail on it. So PCI or CAB is done, and those both of them are more invasive. However, PCI, I think PCI is less invasive and CAB is more invasive. And okay, revascularization, yes, suitable for revascularization. No, then they went to medical therapy. So they will be given drugs. I think this is done in more severe cases. Medication is much more preferred, I guess, but I don't think CABG are much more used. I think medical therapy are much more used, even though the patient might be suitable for the revascularization. These are performed in order to prevent the complications of anginas, might include myocardial infarction and cardiac heart failure. Okay, so high risk patient. If the patient is not high risk then and still persists the symptoms, what if he doesn't persist the symptoms? Then he is well. But okay, but they will usually persist the symptom, I guess. So in that case, medical therapy. What? Yes, if yes, then okay. If still they persist the symptoms, then invasive coronary angiography is done. And after the angiography, they would be looked upon if they are suitable for revascularization or not. Then they would be under the PCI or CABG. And if persistent symptoms, if they don't have persistent symptoms, if they don't have persistent symptoms, okay, they would go to the medical therapy. So just in a brief, I just want to talk this in a brief. I'm still confused, so I want to talk this in a brief. So there is a stable angina on effort. There's stable angina on effort. Okay, effort means stable angina on effort, which means the exercising ECG is done in this case. So if the test is positive, then lifestyle advice is given, secondary prevention is done, and anti-anginal therapy is given in this case. However, if this test is negative, then furthermore tests are done in order to confirm the cases. It includes various CT coronary angiogram and CT scan, coronary angiogram, and review diagnosis. And consider CT coronary angiogram is done. CT coronary angiogram is done, and review diagnosis, and this diagnosis again reviewed. Review diagnosis means this diagnosis is always again reviewed. It should be review diagnosis and consider CT. In that way it would have been easier. So from this, so again we need to give the lifestyle advice, and if the symptom again persists after this, so there is something called this as well. If the patient doesn't suspect the angina, then you should be sent to home, I guess. Send home, no, not exactly they should be sent home, but they must be under the low risk area, you know. They should be under the low risk area if they are not suspected for this case. Lifestyle advice, secondary prevention, and anti-anginal therapy. Persist symptoms, if no, then medical therapy, surgical revascularization, PCR, CVG. Okay. Okay, I actually get it. This is very important thing. If it is in mind, then you can just deal with the patient. Let's read a scheme for this is a scheme for investigational treatment of a stable angina on effort. The selection of a percutaneous coronary intervention. The selection of percutaneous intervention or coronary artery bypass grafting (CABG) depends upon the patient choice. I was talking about it. Yeah, patient might undergo the medical therapy. I was talking about it. So it actually depends upon patient choice, as written here. Coronary artery anatomy. It actually depends on patient choice as well as coronary artery anatomy and extent of coronary artery disease. In general, left main stem and 3 vessels coronary artery disease should be treated by CABG surgery. Anti-anginal drug treatment, yeah. I like reading this kind of thing, you know. Drugs, I love drugs to study. Okay, 5 group of drugs are used to help relieve or prevent the symptom of angina. Okay, they are nitrates, beta blockers, calcium antagonists, potassium channel activators, and IF channel antagonists. I know about nitrate, beta blocker, calcium channel potassium, but I just couldn't recall the IF channel antagonist from my basic knowledge. Okay, let's go to the drugs. Nitrates. These drugs act directly on vascular smooth muscle to produce the venous and arteriolar dilation. So this is artery. There are smooth muscle that are present in this artery. So what the nitrate does do is it acts on these smooth muscles and causes its reduces its contraction. It ultimately causes loosening of the smooth muscle, which ultimately lead to the dilation of artery and venous. Their beneficial effects are due to reduction in myocardial oxygen demand. Actually, nitric oxide is vasodilator. It has to do with nitric oxide, I guess. So let's talk about the function of nitrate in this particular disease. So their beneficial effects are due to reduction in myocardial oxygen demand. Their beneficial effects are due to a reduction in myocardial oxygen demand. So they actually reduce the myocardial oxygen demand. So ischemia is caused due to 2 main factors. Either there is decrease in supply of oxygen, or there might be excessive work of the heart. In those 2 conditions, there might be a condition of there might be ischemia because the heart is not getting enough oxygen. So ultimately, it comes to the oxygen, whether the heart is getting enough oxygen or not to produce energy. So nitrate actually due to reduction in myocardial oxygen demand. So it reduces the myocardial oxygen demand and increase in myocardial oxygen supply. So it works on both ways. It reduces the myocardial oxygen demand and increase the myocardial oxygen supply. It increases the myocardial oxygen supply. Okay. Sublingual glycerol trinitrate administered from the meter dose aerosol. So it can be okay. Sublingual glycerol sublingual. So these nitrates are given sublingually. They are not swallowed. What is the benefit of giving it sublingually? If you give these things sublingually, then it directly goes to the arteries. So it surpasses the hepatic liver. This short part is the liver. So there won't be metabolism on the liver. So it won't go under the metabolism inside the liver. So it is sublingual glyceryl nitrate administered from the meter dose aerosol or as a tablet. It is given in the form of tablet as well. Will relieve an attack of angina in 2 to 3 minutes. I think these drugs are okay. Side effect includes headaches. So side effects includes headache, symptomatic hypertension, and rarely syncope. Rarely syncope. There might be rarely syncope. Symptomatic hypertension and rarely syncope. Okay. Getting it. Okay. Headache, symptomatic hypertension, and rarely syncope. Okay, what is this? Duration of an action of some nitrate preparation. Glyceryl nitrates, these are the most preferred one. Sublingual glyceryl nitrate. EPG action, it reaches. So mechanism of action, no. So it. Okay, duration of action is 10 to 30 minutes. Sublingually, buccal glyceryl nitrate, 4 to 10 minutes, 30 to 300 minutes. Okay, buccal region. I'm confused in this sublingual and buccal region. Both are the same thing. No. Sublingually means you need to keep under the tongue, and in buccal we need to keep it at the side of the molar teeth, and the duration action in that case is longer. Peak action is reached at the same time. So why does the doctor prefer sublingual route? I don't know. Buccal region should be considered. I think it is very difficult to hold the nitrate preparation in the buccal region, I guess. Transdermal, you can get even transdermal patches are also available. It reaches peak action in 1 to 3 hours and up to 24 hours. Overall, isorbide dinitrate is also there, 45 to 220 minutes, 2 to 6 hours. Okay. Oral isorbide mononitrate is there, oral isorbide dinitrate is there, 45 to 220 minutes, 2 to 6 hours. Oral isorbide mononitrate is there, 45 to peak action is 45 to 120 meters for 6 to 10 hours. So isorbide dinitrate has longer duration of actions. Oral isorbide dinitrate and oral isorbide dinitrate, and what are the difference? Okay, this is dinitrate, this is mononitrate. Mononitrate has much more longer mechanism action. Let's see about this. So patients should be encouraged to use the drug prophylactically before taking exercise. Okay, so before any exacerbating factors, we have already discussed the exacerbating factors. It includes various emotional factors, okay, and physical activities, and heavy meals, yeah, like that. So it should be taken before them as a prophylactically. And okay, patients should be encouraged to use the drug prophylactically before taking exercise that is liable to provoke symptoms. Sublingual glyceryl nitrate has a short duration of action. Yeah, as we can see in the figure. However, a variety of alternative nitrate preparation can provide a more prolonged therapeutic effect. Isorbide mononitrate can perform 6 to 10 hours of duration of action. Okay, and can be given transcutaneously as a patch, as well as or as a slow release buccal tablet. Glyceryl nitrate undergoes extensive host-pass metabolism in the liver and is ineffective when swallowed. Other nitrates such as isorbide dinitrate and isorbide mononitrate, okay, can be given by mouth. Headache, okay, headache is common but tends to diminish if the patient perseveres with the treatment. I need to know this term. Perseveres. This is not a term, this is just a vocabulary increasing question. Okay. Word. Perseveres. Perseveres. Yes. What does this mean? Continue in a course of action. Continue in a course of. Come on.
Persevere.
Okay, it is persevere. Persevere. Severe, what the hell? Persevere. Continue in a course of action even in face of difficulty or with a little or no indication of success. Continue a course of action even in the space of difficulty or with little or no indication of success. Statement. Okay. So it is basically without the, so it is just, does this mean idiopathic? No, not idiopathic. What's the term? Placebo. Headache is common but tends to diminish if the patient persevere with the treatment. Okay, if the, okay, I get it. Continuous nitrate therapy can cause pharmacological intolerance. Okay, there might be a pharmacological intolerance. The smooth muscle might undergo intolerance, I guess. This can be avoided by 6 to 8 hour nitrate free period. Okay, best achieved at night. So patients are not advised to take nitrate during night time when the patient is inactive. If nocturnal and so there are actually the condition, there are actually less exacerbating condition at night as well. So it is good to leave the patient nitrate free at night. And then it's predominantly long acting nitrate can be given at the end of the day. Okay. So let's talk about the beta blockers. This lower myocardial oxygen demand by reducing heart rate, blood pressure, and myocardial contractility, but they may provoke bronchospasm in patient with asthma. Okay, this is very important. In case if the patient is both suffering from angina and he or she have asthma, then this beta blocker could act as a poison. It might kill them because there is a bronchospasm in beta blocker. The properties and side effects of the beta blockers are discussed 599. Okay, I don't want to go out there. In theory, non-selective beta blockers may aggravate coronary vasospasm by blocking the coronary artery beta 2 adrenoreceptor, and so a once daily cardio selective preparation is used. Beta blockers should not be withdrawn abruptly as rebound effect may precipitate dangerous arrhythmias, worsening angina or myocardial infarction. The blocker usually in theory, non-selective beta blockers may aggravate coronary vasospasm by blocking the coronary artery beta 2 adrenoreceptor, and so a once daily cardio selective preparation is used. In theory, non-selective beta blockers may aggravate the coronary vasospasm by blocking the coronary artery beta 2 adrenoreceptor. They might block the coronary artery beta 2 adrenoreceptor and might cause coronary vasospasm, contraction of a coronary artery by acting on coronary artery beta 2 receptor. Okay, and so once daily cardio-selective preparation is used. So there might so non-selective means it acts on all the beta receptors throughout the body. However, the cardio-selective preparation acts just on the beta receptor that is present in the heart. So these non-selective beta blockers might act on coronary artery beta 2 adrenoreceptor that might lead to the coronary vasospasm, which might severely aggravate the condition. So in order to prevent that, cardio-selective preparation is used. So release of metoprolol is. So metoprolol is a non-selective, and bisoprolol is selective. Beta blockers should not be withdrawn abruptly as rebound effect may precipitate dangerous arrhythmias, worsening angina or myocardial infarction. Beta blockers should not be withdrawn abruptly as rebound effect may precipitate dangerous arrhythmias, worsening angina or blocker the withdrawn syndrome. Okay, I get it. Calcium channel antagonist. These drugs inhibit the slow invert. Okay, so let's talk about calcium channel antagonist. These drugs okay. I'll be summarizing this drug at last. I'm just reading it. calcium channel antagonist. These drugs inhibit slow inward current caused by the entry of excess calcium through the cell membrane of the excitable cells, particularly cardiac and arterial smooth muscles, and lower the myocardial oxygen demand by reducing blood pressure and myocardial contractility. Slow inward current. These drugs, okay. So calcium is very essential in muscle contraction. And this calcium channel antagonist, as the name suggests, it inhibits the slow inward current caused by it. Okay, so it might it reduces the current of calcium entering into the cardiac and arterial smooth muscle, cardiac muscle, particular cardiac muscle, arterial smooth muscle, and lower myocardial oxygen demand. Okay, oxygen demand by reducing BP. Okay, it does so. It actually, and also, so they also calcium channel antagonists. Okay, this drug inhibits the slow inward current caused by entry of extracellular calcium channel through the cell membrane of the excitable cells, particularly cardiac or arterial smooth muscle, and they also lower the myocardial oxygen demand by reducing BP. They reduce the BP as well. Reducing BP means the heart won't contract much often, which ultimately result in less use of oxygen, and the ischemia decreases and myocardial contractility. So how does it work? It works by providing less calcium in the arterial smooth muscle and cardiac muscle, resulting in less blood pressure and cardiac contractility, ultimately leading to the less condition in which the heart requires less oxygen and ischemia is reduced. So what are the dihydropyridine calcium antagonists such as nifedipine? Dihydropyridine group of calcium antagonists such as nifedipine and nicardipine. Nifedipine and nicardipine often cause a reflex tachycardia. This may be counterproductive as it is best to use them in combination with beta blockers. In contrast, verapamil and diltiazem are particularly suitable for patients who are not receiving beta blockers because they slow SA node firing, inhibit contraction, even node blocker. In contrast, verapamil and diltiazem are particularly suitable for patients who are not receiving beta blockers. Those with error obstruction because I'm not getting. Dihydropyridine calcium antagonists such as nifedipine and nicardipine often cause a reflex tachycardia. This may be counterproductive. Cause a reflex tachycardia. They might cause the reflex tachycardia. This is the side effect. This may be counterproductive, and it is best to use them in combination with beta blockers. So calcium channel. So since this dihydropyridine calcium antagonist group of drugs might lead to the side effect that is tachycardia, they are given with the beta blockers. In contrast, verapamil and diltiazem are particularly suitable for patients who are not receiving the beta blockers. However, verapamil and diltiazem is also another calcium channel antagonist, are particularly suitable for patients who are not receiving beta blockers. Those with air obstruction, okay, because they slow SA node firing. Because verapamil and diltiazem slows the SA node firing, inhibit conduction through the AV node. Okay, slows the SA node firing, inhibit the conduction through the AV node, and tends to cause a bradycardia, and they tend to cause a bradycardia. There are three things they do. They slow the SA node firing, inhibit the conduction through the AV node. They slow the SA node firing, inhibit the conduction through the SA node, AV node, and they tend to cause bradycardia as well. So beta blockers, okay. So it's calcium channel inhibitor for asthmatic patient is verapamil and diltiazem. This sentence just means, this paragraph means that. This paragraph means that. Calcium channel antagonist reduce myocardial contractility and can aggravate or precipitate heart failure. Other unwanted effect includes peripheral edema, forcing headache, and dizziness. Okay, nifedipine may cause marked tachycardia. Nicardipine, these are dihydropyridine group of drug. Dihydropyridine and verapamil and diltiazem are given in case of asthmatic patient. Yes, TH, asthmatic patient. Common causes constipation. Okay. Useful anti-arrhythmic properties. It has anti-arrhythmic properties. Similar anti-arrhythmic properties of verapamil. Both are same. Amlodipine is longer acting, ultra long acting actually. May cause less myocardial depression than the other calcium antagonist. May cause marked tachycardia. Calcium channel antagonists reduce myocardial contractility and can aggravate or precipitate heart failure. Okay. So it might lead to the cardiac heart failure since it reduces the contractility of the heart. So giving calcium channel for the treatment of a coronary heart disease can backfire as a heart failure. Other unwanted effects include peripheral edema, flushing, headache, and dizziness. There might be edema, there might be a flushing, headache, and dizziness. Okay, let's talk about the potassium channel activators. These have arterial and venous dilating properties but do not exhibit the tolerance seen with the nitrates. These have arterial and venous dilating properties but do not exhibit the tolerance seen with the nitrates. Nicorandil is the only drug in this class currently available for clinical use. Okay, IF channel antagonist. Evaporatin is the first of this class of drug. It induces the bradycardia by modulating ion channel in the sinus node. It is the most class of drug. It induces the bradycardia by modulating ion channel in the sinus node. It modulates the ion channel in the sinus node. In contrast to beta blockers and rate-limiting calcium antagonists, it doesn't have other cardiovascular effect. Might be, it seems good. It appears to be safe to use in the patient with a heart failure. Evaporatin, IF channel antagonist. I need to know what is IF. I think I should take a point. IF channel antagonist. Okay. Although each of these anti-angina drugs is superior to the placebo in they are superior to placebo in living symptoms of angina. There is little evidence that one group is more effective than the other. Okay, it is convenient to start therapy with a low dose of aspirin. Okay, I was talking about it previously. Aspirin, statin is also used. Sublingual glycerol nitrate is used, and a beta blockers. And then add calcium channel antagonist, and then there should be addition of a calcium channel antagonist or a long-acting nitrate later if needed. The goal is to control angina with a minimum side effect and the simplest possible drug regimen. There is little evidence that prescribing multiple angina drug is of benefit. Okay, however, the calcium channel inhibitor is given the beta blocker, I guess. But there's little evidence that prescribing multiple angina drug is of the benefit, and revascularization should be considered if an appropriate combination of two or more drugs fails to achieve an acceptable symptomatic response. So, invasive treatment. We already talk about it in coronary arteriography, I guess. Yes. So percutaneous coronary intervention. I was about to search it in search bar, but it's here. Percutaneous coronary intervention is performed by passing a fine guide wire across the coronary stenosis on. Percutaneous coronary intervention is performed by passing a fine guide wire across a coronary stenosis under a radiographic control and using it to position a balloon, okay, which is then inflated to dilate the stenosis. Okay, a coronary stent is a piece of coated metallic scaffolding that can be deployed on a balloon and used to maximize and maintain dilation of a stenosed vessels. The coronary stent is a piece of coated metal. Okay, coronary stent is a, so stent is used in this case. Percutaneous coronary intervention. Stent is used in this case, and there is a balloon, something called a balloon. The balloon is so it is done. Okay, it is done under the radiographic control, and its position just below the coronary stenosis, and the balloon is inflated. When the balloon is inflated, that particular part which have been narrowed and was previously causing ischemia, is now inflated to the stenosis. The coronary stent is a piece of coated metallic scaffolding that can be deployed on a balloon. The coronary stent is a piece of coated metallic scaffolding that can be deployed on a balloon and used to maximize and maintain dilation of a stenoid vessel. The routine use of stents in appropriate vessel use. The routine use of stent in appropriate vessel uses. Percutaneous intervention. I think this is the coronary angioplasty and stenting. Percutaneous intervention. This one is less invasive. I was talking about coronary artery graft. I just forgot the full form. Coronary artery. These things happen. You often forgot the thing that you just studied. Coronary CABG. Coronary artery bypass graft. Just need to remember the full form. What was it? Yeah, bypass graft. Okay, this is PCI, percutaneous invasion. This one is hot. This one is occluded artery. Here the balloon is kept, and this one is atheroma, I guess. Yes, this one must be atheroma. It is inflated and the dilation is complete, and the occluded part is just now unoccluded. Yeah. So what does this? Vascular and vascular balloon dilations. This one is balloon catheter. This is okay. What the hell? It okay. It can be also used in case of mitral valve stenosis, I guess. If the mitral valve is hard enough and it doesn't allow the blood from this left ventricular to this left artery auricle to left ventricle, then this balloon is kept there and it is inflated, and again the blood could enter arterial septal puncture, vascular and valvular balloon dilations. So EBM, angioplasty and intracoronary stent in angina. In comparison with simple balloon angioplasty, intracoronary stents offer superior acute and long-term clinical and angiographic results with lower rates of restenosis and recurrent angina. Restenosis rates are reduced even further with drug-eluting stents. In comparison with the simple balloon angioplasty, intracoronary stents offer superior acute and long-term clinical and angiographic results with lower rates of restenosis and recurrent angina. Okay, I'm not getting this. Angioplasty and intracoronary stents in angina. In comparison with the simple balloon angioplasty, intracoronary stents. Okay, there's two things: simple balloon angioplasty and intracoronary stent offer superior acute and long-term clinical and angiographic result with low rate of restenosis. Okay, there might be a complication of restenosis once this invasive procedure is proceed. And recurrent angina, restenosis rates are reduced even further with drug-eluting stents. And now I need to know what is drug-eluting stents. I guess I could learn this later for further information later. Both acute complication and the incidence of clinically important restenosis. PCI provides an effective symptom symptomatic treatment, but definitive evidence that is improved the survival in patients with both acute complications and the incidence of clinically important restenosis. Okay, I'll be talking about it later. PCI provides an effective symptomatic treatment, but definitive evidence that it improves survival in patients with chronic stable angina is lacking. It is mainly used in a single or two vessel disease. Stenosis in bypass graft can be dilated, as well as those in native coronary arteries. Okay, the technique is often used to provide palliative therapy. For patients with a recurrent angina after CABG. Coronary surgery is usually the preferred option in patients with 3 vessels. Okay, I need to study from first. I'm just not getting it. Just about the time. Percutaneous coronary intervention provides an effective symptomatic treatment, but definitive evidence that it improves survival in patients with chronic stable angina is lacking. So it doesn't improve the survival with the patient having chronic stable angina. It is mainly used in a single or two vessel disease. Okay, single or two vessel disease. Stenosis in bypass graft can be dilated. Stenosis in bypass grafts can be. I'm just confused at this term. Stenosis in bypass grafts can be dilated, and as well as those in native coronary artery. The technique is often used to provide palliative therapy for patients with recurrent angina. The technique is often palliative therapy. I need to know the term palliative. And the treatment during which the patient lies still on a relatively hard top. Treatment calls for. Okay, you might have palliative therapy to relieve bone pain. What is palliative? Okay, palliative care is the care given to improve the quality of life of a patient who have a serious or special type of it is a special type of care which is given to improve the quality of life of the patient who have serious or life-threatening disease such as cancer. Okay. Palliative care is an approach to care that addresses the new person. Okay, I'm good. So do you trust me? I don't trust anyone. The main acute complication of PCI occlusions. So there are many acute complications of PCI, and there are occlusion of target vessel. There might be occlusion. It actually works to unblock them. However, it might work as a blocker or a side branch by thrombus. PCI occlusion of target vesicle or side branch by thrombus or a loose flap of intima. Side branch, thrombus or loose branch of intima, coronary artery dissection. This is called coronary artery dissection, a loose flap of intima, side branch by thrombus or a loose flap of intima, coronary artery dissection, and conjugate myocardial damage. It can cause conjugate consequent myocardial damage. This occurs in about 2 to 5% of the procedures and can be corrected by deploying a stent. However, emergency CABG is sometimes required. Minor myocardial damage, as indicated by elevation of sensitive intercellular minor myocardial damage, as indicated by elevation of sensitive intercellular marker in up to 10% cases. Minor myocardial damage, as indicated by elevation of sensitive in 10% of cases. The main long-term complication of PCI is restenosis. Okay, and in up to 1/3 of the cases, in case of PCI, who are treated this. PCI used to treat the stenosis, but in 1/3 of cases, restenosis is complication. This is sad. This is due to the combination of elastic recoil and smooth muscle proliferation. Why does it occur? It occurs because due to the combination of elastic recoil. I need to know this term: recoil and smooth muscle proliferation, neointimal hyperplasia, and tends to occur within 3 months. Stenting substances initially reduce the risk of stenosis. Probably because it allows the operator to achieve more complete dilation in the first place. Stenting substantially reduces the risk of stenosis. Allows the operator to achieve the more complete dilation of the first place. Drug-eluting stent reduces this risk. Drug-eluting stent reduces this risk even further by allowing an anti-proliferative drug or sirolimus or paclitaxel to elute slowly from the coating and to prevent the neointimal hyperplasia in stent restenosis. I'm not kidding you. There is an increased risk of late stent thrombosis with drug-eluting stents. Although the absolute risk is small, that is 0.5%, recurrent enzyme affecting up to 15-20% of patients receiving intracoronary stent may require for the PCI. Recurrent angina affecting up to 15-20% of the patients receiving an intracoronary stent may require for the PCI or by gastric graft. Okay, the risk of complication are likely success of the procedure are closely related to the morphology of the stenosis. The risk of complication and likely success of the procedure are closely related. Risk of complication and the likely success of this procedure are closely related to the morphology of the stenosis. The experience of the operator and the presence of import comorbidity, example diabetes, peripheral arterial disease. A good outcome is less likely if the target lesion is complex, long, eccentric, or calcified lies. A good outcome is less likely if the target lesion is complex, long, eccentric, or calcified lies on a sprained or within special branch of contains acute thrombosis. I'm just reading. In combination with aspirin and heparin, adjunctive therapy. Adjunctive therapy with potent platelet inhibitors such as clopidogrel. Heparin also giving. Heparin, there are two types of heparin: low molecular weight heparin and high molecular weight heparin. I'll be talking about it later. Adjunctive therapy with potent platelet inhibitors such as clopidogrel or glycoprotein 2B and 3A receptor antagonist improve the outcome of. It improves the outcome of PCI with lower short and long-term rates of death and MI. So in this diagram, what we learn is PCI. In PCI, the major complication is restenosis, and it occurs because due to the elastic recoil and smooth muscle proliferation, and sometimes stenting substantially reduces the risk of stenosis. Probably because it allows the operator to achieve more compatible dilation in the first place. Okay, drug eluting stent. There are some drugs that eluting stents. So drug eluting. I need to know this term, this word, eluting. Remove by washing with a solvent. Okay, drug eluting stents. There might be a stent that is removed by drugs. they actually reduce the risks even further by allowing the anti-proliferative drugs to elute solely from the coating and prevent new intimal hyperplasia, and instant restenosis. I'm not. So what I understand is that there might be some mechanism of removing stent after it is kept in coronary arteries. This is saphenous bypass graft. Okay, so once the graft is in graft is in this artery, artery. So and once it has dilated, that particular part, there must be, once it has dilated this particular part, they must remove that particular stent, because since the artery, because it allows, in order to allow the good blood flow through that particular area. So for that, I think some of the drug is used to elute, means dilute, dissolve it. And the drug, I think and those drugs are what are those drugs? I just studied, I just read. Resistance it is the yes, sirolimus and paclitaxel. Sirolimus and paclitaxel to elute slowly from the coating, prevent the new intimal hyperplasia and instant restenosis. There is an increased risk of latent stent thrombosis with drug-eluting stents. Although the absolute risk is small, there is increased risk of late stent thrombosis with drug-eluting stents. Though the absolute risk is small, recurrent angina affecting up to the 50 to 20% of patients receiving an intracoronary stent or 6 months may require further PCI or bypass grafting. The risk of complication and are likely to risk of complication and the likely success of the procedure are closely related to the morphology of the stenosis. The experience of the operator and the presence of the important comorbidity in diabetic arteries, the risk of complication and the likely success of the procedure are closely related. The risk of the complication of the disease and the likely success of the procedure are closely related to the morphology of the stenosis. Okay, so it actually depends on the morphology of the stenosis, how the stenosis is, the experience of the operator and the experience of the, so it also depends upon the doctor. So you need to study very well, and the presence of important comorbidity. Okay, it actually depends on 3 factors. Number 1 is the stenosis itself. Number 2 is doctor. And number 3 is patient, which means the condition of the patient, such as if he is present with any diseases such as diabetes and peripheral arterial diseases. Okay, so good outcome is less likely if the target lesion is complex or long eccentric or calcified, lies on the behind or within the dorsal vessel, involves a branch of containing acute thrombus. In combination with the aspirin, aspirin and heparin is given in order to prevent this is and the aspirin is antiplatelet when given in 0.75 gram, I think. Yes, antiplatelet, it gives an antiplatelet action. Similarly, there is drugs such as clopidogrel, which is actually an antiplatelet drug. And heparin, on the other hand, is blood thinning. Heparin actually reduces the formation of clots as well. There are 2 types of heparin, according to my knowledge: low molecular weight and high molecular weight. I just need to understand about it, and you just need to read about it. And then we have something called as coronary artery bypass grafting, very important. The internal memory arteries, radial arteries, or the reversible segment of vein can be used. Okay, there are 3 arteries. Number 1 is internal memory arteries. Radial arteries or the reverse segment of patient on CPAP. I was talking about saphenous vein. I knew that. So the saphenous vein is used in coronary artery bypass grafting. Other arteries can be used as well, such as internal memory arteries and radial arteries. So radial arteries, internal memory arteries, as the name says, is in the mammary gland. And radial arteries, the radial arteries. I need to know the location of radial arteries in my brain. What is radial arteries? Radial arteries. Heart mount. It must be in hand, I guess. I just forgot. It happens. Anatomy is too much volatile. Yeah, I was right. Okay. It is in hand. Come on, damn it. There is. I need to know this. I need to know this. Let's try anatomy in a brief. In a short. So radial artery can be used, internal memory artery can be used, and the other thing that can be used is vein, saphenous vein. Internal memory artery, radial artery, and saphenous vein is used in case of coronary artery bypass grafting. This is important. This term is important. This usually involves them is okay. So we need to know about the recurrent radial artery. This one is radial artery. This is lateral, so it is called radial. This is ulnar artery. Below it there is ulnar bone, ulnar artery and radial artery. So this radial artery can be used, and other artery that can be used is internal memory artery. Okay, shit. This shouldn't be showing. This usually involves major surgery under cardiovascular. This usually involves major surgery under cardiopulmonary bypass, but in some cases, graft can be applied to the beating of the heart. Okay, can be used to bypass coronary artery stenosis. This usually involves major surgery under cardiopulmonary bypass, but in some cases, graft can be applied to the beating heart. This usually involves major surgery. So CBG is major surgery, and in order to implant these particular arteries in that particular heart requires a major surgery under cardiopulmonary bypass. But in some cases, graft can be applied to the beating heart of pump surgery. Beating heart. The operative mortality is approximately 1.5%. Among 100 operations done, among 200 operations done, 1% dies. Is it? No, 3% dies. But risks are higher in elderly patients. Risks are higher in the elderly patients, those with the poor left ventricular functions, and those significant comorbidities such as renal failure. Approximately 90% of the patients are free of angina. Approximately 90% of patients are free of angina 1 year after the CABG surgery, but fewer than 60% of the patients are symptomatic after 5 years or more years. Okay, are free of angina 1 year CABG, but fewer than 60% of the patients are symptomatic after 5 or more years. Okay, very difficult for the persons who have gone under major surgery and still have this disease. Early post-operative angina is usually due to graft failure arising from technical problem during the operation. Okay. Post-operative angina is usually due to graft failure. If there is failure of graft, again the angina occurs. That might be due to technical problem during the operation, or poor runoff due to the disease in the genetic coronary. Fewer than 50% of vein grafts are patent 10 years after surgery. However, arterial graft have much better long-term potency rate, with more than 80% of internal arterial graft patient at 10 years. This had as many surgeons to consider total arterial revascularization during the CABG surgery. Okay, total arterial revascularization during the CABG surgery. Aspirin and clopidogrel both improve the graft potency, and one or other should be prescribed indefinitely if well tolerated. Intensive lipid lowering therapy slows the progression of the disease. Intensive lipid lowering therapy shows the progression of the disease in the native coronary arteries and bypass graft, and reduces the clinical cardiovascular events. There is substantial excess cardiovascular morbidity and mortality in patients who continue to smoke after bypass grafting. Persistent smokers are twice as likely to die in the 10 years following surgery than those who give up at surgery. CABG improves survival in symptomatic patients with left main stenosis and 3 vesical coronary disease. Okay, this comparison of a PCI and CA very important. I think I need to screenshot this. I'll be taking it later. So death 0.5% is death, 1.5% 200, 3 or 200 surgery, 200 1 death in 200 surgery. Myocardial infarction 2%, what the hell, 2%, 10%, hospital stay 13 to 36 hours. Return to work 2 to 5 days, 6 to 12 weeks, lot of time. Recurrent angina, 15 to 20% of people observe recurrent angina even after the surgery within the 6 months. So it is good at this. 10%. However, I think this PCI is good. Repeat revascularization. Should we repeat the revascularization? 10 to 20% at 2 years, 2% on 2 years. Okay, it is good in this case and this case. It is good in this case, and this case. Neurological complication rare, common. Okay, this is good in this as well. And other, what are the other complication of PCI? Emergency CABG vascular damage related to SS site. Are you serious? CABG vascular damage related to SS site. Diffuse myocardial damage infection. There might be diffuse myocardial damage infections defined as CKMB greater than 2 normal. Okay, it is in paste. Diffuse myocardial damage infections. So it is good in case of these two terms. There is less of a recurrent angina and repeat revascularization is very less than the PCI. However, the death is more in case, death is very less in case of PCI. On myocardial infection, not very less, same, I would say. It is not that of a concern because this is very low range in case of if a single patient is concerned. And the myocardial, it also depends upon the doctors, as we have studied. Let's talk about the myocardial infarctions, higher in case of CABG. Hospitals say, yo, this is very good factors. This is postponed in case of PCI. Only 12 to 36 hours of hospital stay, and you can repeat the work in 2 to 5 days. PCI, in case of PCI, there's 5 to 8 days and 6 to 12 weeks. 6 to 12 weeks means how many months? Approximately 4 months. 1 to 4 months. 1 month, 1 week, 1 month, 2 weeks, 1 month, 1 week to 4 months. So they need to take the vacation for 4 months in case of CABG. That is good. Comparison of PCI and CABG surgery in stable angina. Let's talk about comparison. Okay, systemic reviews and meta-analysis have found similar rates of death and myocardial infarction and similar quality of life. PCI is associated with a greater need for repeated procedure. This is important. In case of PCI, the repeated procedure is done very often, should be done, although this has been halved by the introduction of intracoronary stent implantation. Okay. For patients with multivessel disease or diabetes, CABG appears to confer better survival rates. So if the patient is present, generally the patient with the angina is present with the diabetes, generally, and multivessel disease. So they undergo CABG surgery, coronary artery bypass graft surgery. PCI is good for those. It should be done regularly. However, after the introduction of what we call stent, it has been reduced very. That is very good. Okay. I don't need to go. So proximal LAD left art. Actually, just a minute. Wait. LAD left. LAD. Okay, two vessel disease involving the proximal left. Okay, I just forgot. There are, but I need to know the basic of the heart. I know this LAD, diagonal. left auricular diagonal coronary artery LAD, proximal right auricular artery and left auricular artery, proximal left auricular coronary artery. Okay, improvement in survival is most marked in those with impaired left ventricular. Improvement in survival is most marked in those with impaired left ventricular function or positive test testing prior to surgery, and in those who have undergone left intermedullary artery grafting. Neurological complications are common with 1 to 5% of risk of perioperative strokes. Between 30 and 80% of patients develop short-term cognitive impairment that are typically resolved within 6 months. There are also reports of long-term cognitive decline that may be evident in more than 30% of the patients at 5 years. PCI and CBC are compared in boxes sitting. Okay, I already studied. Prognosis. Symptoms of the poor guide to prognosis. Nevertheless, the 5-year mortality of patients with a severe angina. Symptoms are poor guide to prognosis. Symptoms are prognosis. Symptoms are poor guide to prognosis. Nevertheless, the 5-year mortality of patients with severe angina. Symptoms are poor guide to prognosis. Nevertheless, the 5-year mortality of patients with severe angina is nearly double than that of patients with mild symptoms. The poor guide symptoms are a poor guide to prognosis. Okay, the 5-year mortality of a patient with severe angina are nearly double that of patients with mild symptoms. Okay, exercise testing and other forms of stress testing are much more powerful predictors of mortality. For example, in one studies, the 4 years mortality of patients with stable angina and 4 years mortality of patients with stable angina and a negative exercise test was 1% compared to 20% in those with a strongly positive test. I need to study this again. Exercise testing and other forms of stress. And other forms of testing and much more powerful. Exercise testing and other forms of test testing are much more powerful predictor of mortality. For example, in one study, the 4-year mortality of patients with stable angina and negative exercise, that was exercise testing and other factors of mortality. For example, in one studies, the 4-year mortality of patients with stable angina and 1% compared to more than 20% in those with a strongly positive patient. In general, the prognosis of coronary artery disease is related to number of decreased diseased vessels. In general, the prognosis of the coronary artery disease is related to the number of diseased gall vessels. In general, the prognosis of the coronary artery disease is related to number of diseased vessels. In general, prognosis of the coronary artery disease is related to number of diseased vessels and the degree of left ventricular dysfunction. A patient with single vessel disease and a good left ventricular function has excellent outlook, whereas the patient with a severe left ventricular dysfunction and the extensive disease have poor prognosis. Without revascularization, spontaneous or symptomatic improvement due to the development of collateral vessel is common. Okay, angina with normal coronary arteries. Approximately 10% of the patients who report stable angina on effort will have angiographically normal coronary arteries. Okay, when done angiograph, their arteries are normal. Many of these patients are women, so it is more common in men. We have already studied. Many of these patients are women, and the mechanism of symptoms is often difficult to establish. So there's no known systems. It is important to review the original diagnosis and explore the potential causes. Coronary artery spasm. Vasospasm in coronary arteries may coexist with the atheroma. Vasospasm in coronary artery may coexist with the atheromas. Okay, there might be, especially in unstable angina. In less than 1% of the cases, vasospasm may occur without angiographical detectable atheroma. Okay, so there is vasospasm in coronary artery, but during the angiogram there is no evidence of atheroma, but there is actually atheroma in the real case. This is sometimes known as variant angina. So what do you mean variant angina? So variant angina is in a condition in which there is vasospasm of a coronary artery, where vasospasm of a coronary artery in which the atheroma is not seen angiographically. However, there is presence of atheroma in real. Okay, angiographically, and may be accompanied by spontaneous and transient ST elevation on ECG. Spontaneous and transient ST elevation in the ECG. Prismental's angina. This angina. So Prismental's angina. Calcium channel antagonist nitrates and other coronary vasodilators are the most useful therapeutic agents, but may be ineffective. Syndrome X. The constellation of typical angina on effort. Syndrome X. The constellation of typical angina on effort. Objective evidence of myocardial ischemia on stress testing and angiographical normal coronary arteries is sometimes known as syndrome X. Again, I need to know this, what is syndrome X. The constellation means combination of typical angina on effort, objective evidence of myocardial ischemia, on stress testing, and angiographically normal coronary arteries is sometimes objective evidence of myocardial ischemia on stress testing and angiographically normal coronary artery. Myocardial ischemia on stress testing. So there is angina on effort and myocardial ischemia on stress testing. However, there is no presence of atheroma angiographically. It is sometimes. This disorder is poorly understood but carries a good prognosis and may respond to the treatment with anti-anginal therapy. So this is very less understood. However, there is no need to worry if the patient is suffering from syndrome X. It is just a combination of three factors that are three things that are angina on effort, objective evidence of myocardial ischemia, and negative coronary arteries stenosis. It's called syndrome X. What is the difference between variant angina and syndrome X? If the patient with the syndrome X is suffering from variant angina. Today we're going to, okay, now is time for acute coronary syndrome. Acute coronary syndrome. Let's see how much pages are there. A lot of pages.